Senator Paterson.
Thank you very much, Chair. And I'll start my questions with Professor Murphy, because I believe that his time is more limited today, and we said we might return to you later. But I just want to flag at the outset, I know departments have been invited to make submissions to the committee. One thing which would be helpful, either in the Department of Health submission or in the PM&C submission from a whole of government point of view, is a timeline of decisions made by the federal government that will allow the committee to ask appropriate follow-up questions about those decisions.
We're very happy to provide that. We can provide a more detailed timeline of actions and decisions, if you like, of the whole. We can provide a comprehensive timeline of how it's all evolved.
Thank you.
That would be excellent. Thank you. And Professor Murphy, thank you very much for your time today and your leadership throughout this crisis. One of the challenges for this committee is that we have to be both backward-looking, because we are a scrutiny committee of decisions made by government, and also forward-looking, because certainly our constituents expect of us to help them give a better picture about what their weeks and months are going to be like, to the extent that we can. So with the constraints of time, I want to ask a few questions about the road in and a few questions about the road out. Firstly, on the road in your view, what were the key, most important decisions that the government made? And the reason why I ask that is because if we can identify what the most successful interventions we have made, that will give us some picture of where we're heading as we look hopefully to relax those restrictions in the future.
Thanks, Senator. So in terms of government decisions, I'd have to say that government decisions, both federal and state, have at all times been advised by the consolidated national advice from AHPPC. So I've been incredibly pleased and impressed by the way every government has taken the medical advice and responded to it. So in terms of government decisions, the most important early decisions were related to border measures. They were difficult decisions. We made a decision to initially not allow any flights from Wuhan without very careful health screening, and then they stopped, and we put border measures in stopping all flights from China. We put border measures in stopping people coming from Iran, Republic of Korea, and we then started some very enhanced border measures and progressively hyped up our recommendations to DFAT to increase the travel advisories, and in the end we have now really closed our borders. And it's really important to note that 2/3 of the cases of COVID-19 in Australia have been in returning travellers, and border controls, including the most recent and most restrictive border measures, which is to formally quarantine in hotels every return traveller, have been quite challenging for government, but I think they have been one of the biggest reasons for our success. Other important decisions have been to invest very substantially in testing. The reason that we are not in the position of the UK or the US is because we were well prepared. We had our public health laboratory network, our AHPPC, all of our structures, all of our national federated structures, but we got going with our public health laboratory network to develop in-house testing before there were any commercial testing. We tested widely. We have had one of the highest testing rates in the world. We got on top of all of those early cases out of China in late January and February. We identified them, quarantined them, isolated them, and in other countries they spread. So getting on top of the testing and tracing and isolation and really upskilling the public health units in each of the states and territories put us in a position where we have at no stage had widespread undetected community transmission like those other countries have. Then, of course, comes when we had some community transmission, particularly in Sydney and in Melbourne, the very difficult decisions that were made in March to introduce progressive social distancing measures, because despite our very strong testing and contact tracing and isolation measures, once you have community transmission where you don't have an identified contact, you have to control that by reducing human contact. And so as the epidemiology evolved and the National Cabinet was formed, we had a nationally consistent approach to, we don't like the term lockdown that some countries and some commentators have gone for, but basically to introduce a progressive range of social distancing measures to reduce that community transmission, and that has certainly been what we've seen. So the three sets of measures: huge investment in public health response, border measures, really strong border measures, some of the strongest in the world, and then the measures around social distancing.
Thank you. And just on those border measures, they were, as you say, among the earliest in the world and the strongest in the world. In fact, we not only moved ahead of the recommendations of the World Health Organization on those matters, but I guess indirectly the World Health Organization made criticism of measures such as that. Why is it that Australia moved ahead of the World Health Organization and other countries?
Because we saw ourselves, we had a huge amount of traffic from China, which was the initial, we had, I think, a very, very large number of flights. I think it was 160 plus flights a week from China. China was clearly in that early phase the epicentre, and it wasn't just Hubei province, it was spreading rapidly in other provinces of China. And we knew that the greatest risk to uncontrolled transmission was in imported cases. And as an island, we were in a position of perhaps doing border measures more effectively than other countries. And so the unanimous health advice of the Health Protection Principal Committee was we should do that. And I conveyed that to the Health Minister and the Prime Minister. I recall it on a Saturday morning, and those measures were introduced that night. We had an urgent convening of the National Security Committee. So I think in retrospect, our colleagues in the UK and the US regret that they didn't do the same.
Australia is obviously one of the leading countries in the world in terms of the health results. There are only a few other countries that can boast the result that we've got. To what extent are you, though, evaluating those countries? Of particular interest to me is Taiwan's success in combating the virus, because they appear to have done so with less stringent restrictions than even Australia has. Are you studying their response, and why do you think they've been successful?
Good question, Senator. So Taiwan, as I said, our strength has been our public health response plus border measures plus social distancing. Taiwan certainly have introduced strong border measures, and they have a very strong public health response. Very, very aggressive contact tracing and isolation. That is what we, at the request of the National Cabinet, are now looking at in terms of can we reduce some of our distancing measures by enhancing even further our public health response, and that means testing like you've never tested before. We've got one of the best testing rates in the world, but we want to do even better, because the risk, if you remove any social distancing, is you can get a community outbreak. And we've already seen, in northwest Tasmania, a small community outbreak related to healthcare workers that has been needed to be controlled in a very excellently controlled, I should say, by Tasmanian Health. So Taiwan, I think, is a good example of very strong public health measures. Singapore is interesting. They have a very similar approach to us, but they've now had a second wave in their migrant worker population, and we have to be very, very aware that whilst we've only had 7 cases over the last 24 hours, we're in a wonderful position, but there is a permanent risk of further waves, and this is a highly infectious virus and it can take off fairly quickly. So we are certainly watching those like-minded countries, yeah.
Thank you. And just turning quickly to the road out in my remaining time, a particular interest in the media today I noticed is the issue of schools. That's been an ongoing debate. You've been very clear throughout this that the AHPPC's advice hasn't changed, that it is safe for schools to remain open with appropriate measures in place. I just want to drill down a bit into why that's the case. So as a starting point, of the 6,500 roughly cases in Australia, how many of those are children?
The proportion of children is very small. The under 10, I think it's only a handful. There are some more in the teenager group. I haven't got the exact numbers with me. I can provide that for you. But we're talking generally internationally, it's about under 19, it's about 2.4% is the figures from across the world. What we've seen in Australia is hardly any cases under 10, a small number of cases in teenagers. Most of those have been family contacts, the children and the teenagers. We've now looked at, and New South Wales Health has done some very good work looking at cases that have occurred in schools, and they have found really no evidence of student-to-student transmission in schools. There have been some instances of student-to-teacher and teacher-to-teacher, but it's very interesting, completely unlike influenza. This virus doesn't seem to infect children as much. There is still uncertainty about whether they may have asymptomatic infection, but if they do, they don't seem to be transmitting it in schools. So we don't think the school environment is a high risk for transmission from children to children. We have had concerns about adults and vulnerable teachers, older teachers, teachers with chronic disease, and adult-to-adult transmission in the school environment. So the measures that we've recommended have been around that. And this HPPC advice, which is all of the state and territory chief health officers, has been very consistent on that basis.
Thank you. So perhaps on notice, if you could just provide the number of children who have been infected, any confirmed cases of children-to-children infection, and any confirmed cases of children-to-adult infection, because I think that would help build a picture about why it is safe, why your very clear and consistent advice has been for schools to open with appropriate measures in place. Chair, I think I'm probably getting quite close to my 15 minutes. Any advice on that?
Thank you. You are very close. Are you
okay. Just one final question then, Professor Murphy. To what extent over time has our understanding of the seriousness of the virus changed? I'd be very interested in your advice on the CFR and IFR measures of seriousness of the virus based on the data we've had. So, for example, in the very early stages when we only had the data from Wuhan compared to now when we have much better Australian data and data from elsewhere in the world, has your picture of the seriousness of the virus changed in that time?
Not materially. My view is that the case fatality rate is around 1%. There are lots of countries with much higher fatality rates, and our view increasingly is that's because they're not ascertaining cases. Those countries like us that have tested widely and have good ascertainment generally get, like the Republic of Korea is a good example, Germany's a bit closer, but they've probably missed some cases too. But we think that if you're capturing widely, we are seeing about a 1% case fatality rate. We are consistently 80% of cases across the world are mild. And one of the challenges has been that some are so mild, like in Italy and America, you had probably thousands of people infected, particularly if it's in a flu season in the winter, and people just didn't know that this was COVID circulating around. So we've only seen a relatively small number of people who've required hospitalisation and intensive care treatment. Most people have been perfectly able to be managed. So the challenge is, and that's why one of the reasons it's so infectious, is so many people have mild disease and will continue to go to work or continue to circulate in the community. But unfortunately, that small group, mainly elderly people and those with chronic disease, can get a very serious viral pneumonia and die.
Okay, so just one final follow-up question then on that, Chair. There are some commentators who suggest that there likely to be widespread asymptomatic infection in the community that we haven't picked up yet because we haven't done sufficiently widespread testing. How likely do you think that is in Australia?
Very unlikely, Senator. We have been doing sentinel testing across a range of GP practices for weeks. We have been testing every unusual pneumonia that comes into a hospital and not found any. And we're now we're testing in most jurisdictions at the moment. We're testing every single person who has acute respiratory illness. South Australia's been testing very widely from early on. All the other jurisdictions are now doing it. I think if we would have found evidence of this, clearly there is probably some, but I don't think there's widespread community transmission in Australia at this stage.
Okay,
right.
that's
Thank you, Chair.